Welcome to Voice for Infection Prevention, where we explore the latest developments, challenges, and insights in the field of infection prevention and control. With a passion for promoting patient safety and healthcare excellence, we're excited to bring you engaging discussions with experts, leaders, and innovators in the field. So whether you're a seasoned professional or just beginning your journey in infection prevention, welcome to the conversation. This is Voice for Infection Prevention.
Welcome back to Voice for Infection Prevention. I'm Jacob Hutcherson. Today's episode is brought to you by Germitec. Germitec is a medical technology company focused on ultrasound probe disinfection through UVC high-level disinfection systems. In this episode, we're stepping back and looking more broadly at UVC as a high-level disinfection approach, what the standard actually requires, what has to be true for a system to be clinically credible, and how this kind of technology may fit into real healthcare workflows. I'm joined by Dr. David Weber, who has spent decades working in healthcare epidemiology and infection prevention. He has led hospital epidemiology at UNC Hospitals for more than 35 years. He currently serves as President-Elect of SHEA and has published extensively on healthcare-associated infections and disinfection. Today, we're talking about a topic that sits kind of at the intersection of infection prevention, disinfection standards, and medtech innovation. So high-level disinfection for endocavity ultrasound probes, and specifically what it takes for a UVC system to be taken seriously in the clinical setting. So I'm not a practicing infection preventionist. I just talk to a lot of them and have for the last 15 years. But my role today is really just to ask some questions that I think the audience would want answered kind of clearly and practically. So I'd like to start off kind of big picture before we actually get into the technology itself. So before we talk about UVC specifically, could you help maybe ground us in the clinical importance of this category? Like, why are endocavity ultrasound probes treated differently than some of the lower risk devices?
So many decades ago, a physician named E.H. Spaulding developed a classification for how different medical devices need to be cleaned and disinfected between patients to prevent transmission of pathogenic germs, bacteria from person to person. And this was based on the degree of infection risk with their use. And this classification has lasted for decades. So he had three categories. The first were items that he called critical. These are items that have contact with sterile tissue or the bloodstream. This would be something like surgical instruments, for instance, that are being used in the abdomen. And those should be sterile. And this was used in an absolute sense, meaning that there are no microbes left on those after cleaning, and in this case, sterilization. The second category he listed is semi-critical. These were devices that had contact with non-intact skin or mucous membranes. Now, these would be things like endoscopes that come into contact with the GI mucosa, endocavity ultrasound probes that are placed into body cavities, for instance. These have to be high-level disinfected. High-level disinfection will eliminate all the microbes, except it might not eliminate high numbers of spores. It will eliminate spores, but might leave a few behind. And then finally, there were non-critical items, the third class, and these were devices that came into contact with intact skin, something like a blood pressure cuff. And for those, we use low-level disinfection. Stethoscope would be another example. And we also, when we disinfect surfaces, like the surfaces in a patient's room, those are also using low-level disinfection. But it is important for endocavity probes that enter a body cavity and touch the mucous membrane, to be high-level disinfected. And endocavity probes can be used in several ways. They can be placed in the esophagus for using cardiac ultrasound. You get better visualization from the esophagus than you do from the surface. We can use rectal ultrasound probes, most commonly used to visualize the prostate and assess the possibility of cancer. And we use vaginal probes to assess usually the ovaries. For those, we start with cleaning any material that's on the probe, and then we use high-level disinfection, which will eliminate all the dangerous organisms such as multi-drug resistant gram-negative bacteria that could cause infections, agents that cause sexually transmitted disease, human papillomavirus, which can be in the rectum and the vagina, which can cause cancer. And the goal then is to treat the probe so that there's no carriage of anything harmful from one patient to the other.
Got it. Okay. So the starting point here then is these probes are in a category where the required standard is already high. So any new technology just kind of has to meet that bar, correct? Not redefine it.
That is correct. And there is an absolute bar here. So for high-level disinfection, what you have to do is inactivate or kill at least 1 million viruses, bacteria, fungi. These are levels which generally greatly exceed the possible level of contaminants that might be on it from use on a previous patient. In addition, it will eliminate large or substantial numbers of fungi, but might not inactivate all the spores. But spore-forming pathogens that could be transmitted from person to person, one, they're uncommon, and two, there aren't many that would actually cause disease. And of course, the mucous membrane itself has lots of white cells and also protects the body, and it's different than something that's actually entering the body. So it's felt that for this particular use, something that goes into a body cavity or then you just need, or non-intact skin, you just need to use high-level disinfection. But again, you have to demonstrate that you can kill 1 million viruses, bacteria, fungi, and the FDA gives you specific types of viruses, bacteria, and fungi that you have to demonstrate that on.
Gotcha. Okay. So UVC, that's something that can sound deceptively simple from the outside. It's almost like a shine a light on it and you're done. And then I know UVC is almost like a buzzword these days. I feel like I see it everywhere. So my very elementary understanding, that was kind of my perception. So I want to ask you that what do people usually misunderstand about what it actually takes for UVC to deliver true high-level disinfection?
Of course, people are familiar with UV. It comes through the atmosphere, not UVC, but some of the other types of ultraviolet light obviously gives you suntans and sometimes burns, and that's why obviously you use sun-blocking agents. But at the right level, which we call UVC, one of the types of UVC, but specifically 254 nanometers, which is the wavelength, it effectively kills or inactivates microorganisms, including bacteria, viruses, and fungi. It does so by damaging their DNA and RNA, preventing those microbes from replicating. Now, I should say this type of germicidal, meaning killing germs, or radiation, is widely used in healthcare. We have so-called UVGI processes that are put into air ducts to disinfect the air. We have multiple devices in the hospital to disinfect surfaces that use UV. And how well it works depends on the distance. So the longer the distance, the less active it is. Short distances, it works better. How much energy you supply, and how long it's used for, the duration. So it's most effective at short distances, high energy, such as you would find in a chamber in which you would place an ultrasound probe.
So is the dose and the coverage, is that really the dividing line between something that achieves like meaningful clinical endpoint versus just something that reduces surface contamination?
The answer is yes. So the amount of energy is delivered falls off as a square of the distance. So it means if you go from 1 inch to 2 inches, you get half as much. You go to 4 inches, you get a quarter as much. So it becomes much harder to achieve high-level disinfection, virtually impossible at a long distance. That's why we just use it for surfaces that don't require as much kill. But when you're in a chamber and you're literally just a centimeter or two from the bulbs to the device, it rapidly is very effective in killing organisms. In addition, in these chambers, you have lots of mirrors, so you cover every single surface of the device.
Gotcha. So how big of a problem is the line of sight and shadowing when it comes to dealing with real devices rather than flat surfaces?
So in patient rooms, it's a substantial problem. So if you had the back of a chair, the chair's facing the device, you have to bounce the UV off the wall to the back of the chair, which does happen, but only about 3 to 7% of the UV is reflected that way. When it's used in a closed chamber, you have multiple bulbs, you have mirrors, so every single part of the device gets a full dose of the UV. And again, you're only half an inch away from that. So the closed chamber accommodates ultrasound probes of different sizes, and it's designed to deliver a very high dose in a very short period of time.
Okay. So the takeaway here, I guess, is that UVC isn't the story by itself. It's kind of the controlled delivery is really the story here. So if we look at it, if the science is one thing, then obviously real world translation is another. So what has to be engineered, controlled, and validated for a UVC system to become clinically reliable rather than just like a conceptually promising concept?
Well, the first thing is you need a closed chamber, obviously, that's safe. So meaning while the UV lights are on, it won't open. That seems fairly straightforward. Has to be big enough to allow probes of different sizes to fit into that. Again, because you're so close to the device here that is used for ultrasound probes, one, it's very fast, less than 2 minutes. Unlike chemicals, there are no harmful residues. Again, it kills at least 1 million relevant microbes. It's automated so that the amount of dose is being measured, and the device wouldn't turn off until you had completely assured high-level disinfection. I already mentioned it's safe for the people using it. It's also safe for future patients because there's no chemical involved. If you use a harmful chemical that would actually kill microbes, generally you have to rinse it off the device so it doesn't injure the patient it's used on. But here there are no chemicals there. And the device is built with readouts to assure that you achieve high-level disinfection there. So you have to go through all of that. And then to meet FDA approval, you have to prove this million killing for multiple specific microbes that the FDA believes are important human pathogens.
Gotcha. And then one quick follow-up, where do you think the real innovation lives today? I mean, is it in the light source itself or the chamber design or the monitoring or the validation strategy or the workflow integration or just kind of all of it?
It's all of it there. You have to get all of those things you mentioned correct. And again, then you have to demonstrate in real life situations, either by taking a probe that you purposely put all the microbes the FDA requires, and these tend to be the more resistant microbes on the probe, or you need to take it out in the real world and make sure it works. Particularly arranging the orientation of the bulbs, covering it appropriately with mirrors, building in not one but two separate devices that measure how much energy is being used, automating it so that it provides you a readout either electronically or on paper for future use. All of those have to be done. So it's not straightforward. And I should say the UV device that we're talking about is the first UV device to be approved by the FDA. It's much easier to get any medical device approved if there are already 20 of them like that. So if you want to get a new thermometer approved, electronic thermometer, which there are many, the FDA has done that many times. It'll tell you exactly how to do it. Here was a little more difficult because the FDA hadn't yet come out with their guidelines about how to get it approved. And so it took a little longer to go through and develop with the FDA all these specific guidelines and then demonstrate the key thing is that the device is always effective and always safe.
Gotcha. So, and you kind of hit on my next question a little bit. I mean, using Chronos as an example here. So I know you mentioned that it was a long, kind of difficult thing, but using Chronos as an example, what did it take to move from kind of the general promise of this to something that could actually be cleared and used in this category?
Again, I was developing the interior part of the chamber, the orientation of the bulbs and the mirrors, developing a sensing system that senses how much UV irradiation is done, multiple sensors to make sure that you know it was high-level disinfected, developing a monitoring system that will allow you to either electronically through paper determine that you've met that, and then obviously developing different size chambers that would handle like a rectal probe, which is, whatever 6 to 10 centimeters, from an esophageal probe used for looking at the heart, which can be more than a meter long, developing different size chambers to handle all of those. One other thing I do want to mention is that we're all familiar with multi-drug resistant microbes, so they get exposed to antibiotics and sometimes to chemicals. They will try and develop resistance to not being killed by those antibiotics or chemicals. But for UV, well, some organisms like spore formers are a little more resistant. You need either higher energy or longer time or both to kill them. There is no evidence that these microbes can develop resistance to UV, which is another advantage of using ultraviolet light.
Wow. Okay. So the differentiation here isn't that UVC exists. The differentiation is really whether it can be delivered consistently and safely, documentably, and then also at the standard that the category requires. So from the hospital side, the question's never just does it work? It's also what does this mean operationally? So how should infection prevention leaders think about UVC compared to traditional chemical high-level disinfection workflows?
Well, first of all, the older days, we would use trays with chemicals in them. They are quite hazardous for high-level disinfection. You often needed to specially ventilate the room. Healthcare providers using them needed to wear personal protective equipment, things like gowns and gloves, so that they didn't come into contact with the chemical. All those, even the newer ones, you still have to rinse them to remove the chemicals there. There's some hazard. There are concerns what the chemicals will do because you have to dispose of them in terms of the environment. They, in general, would be longer than the time it takes for UV to work, which is less than 2 minutes. And of course, there are no residuals and there's no harm, nothing to be disposed of into the environment there. So there are many advantages to UV over standard and even newer chemical disinfection.
Where do you think the operational advantage is the most meaningful? Just from your time, where are you seeing the biggest impact?
Well, I see two advantages from my view as a hospital epidemiologist, infection preventionist. The things here are complete safety to the personnel and high-level rapid disinfection with no need to wash things off so that you could harm the patient. And of course, the last thing we want is to take from patient A to patient B and carry over harmful microbes from one to the other, like human papillomaviruses, which could cause cancer. So that's the advantage from an infection prevention standpoint. From a user standpoint, the major advantages are incredibly fast, less than 2 minutes. Obviously, that means you need less machines and less turnover time, depending how many probes you would have between use on each patient. And essentially, it's really simple to use. You do have to clean, and cleaning always precedes, no matter what disinfection method you use, precedes disinfection. But then you just put it in the device, you push the button, turn it on. Less than 2 minutes later, you take it out, and it's immediately ready to be used. And the device is incredibly fast. There's no warm-up time. You don't have to put any disposables in there like chemicals. There's nothing to send down the sewer system. There's no rinsing. So from a user time, this is incredibly easy and safe to use. Allows you to turn over patients faster.
Amazing. So tell me this, where are the limits? So like, in other words, where does UVC fit well? And then where are hospitals still going to need traditional chemical workflows or other reprocessing approaches?
Well, of course, this has been validated for endocavity probes. It potentially could be used at some point in the future for other devices that need to be high-level disinfected. Something like a specular, which is used on a woman as a when you're doing a pelvic exam or a fitting diaphragm. Theoretically, you could use UV like this. The one limitation, of course, is the UV has to touch every surface, and it's designed that way. So if you have a device like an endoscope with tubes going down the middle, you couldn't use UV. There you have to use a gaseous chemical or a liquid chemical and force it into through the tube. So UV doesn't have a way of disinfecting endoscopes that have tubes in them. That's really the major limitation. But for other devices, certainly its use in the future can be potentially expanded. Again, one has to demonstrate that you can appropriately disinfect all the surfaces, and of course, you want to prove that it doesn't somehow damage the device.
Gotcha. And so as you look ahead, where do you see, or where do you think systems like this fit into the future of infection prevention infrastructure? So is this a niche solution, or do you think this reflects a broader shift in how hospitals will think about disinfection workflow?
No, I think it's a paradigm shift for the reasons I said. I think large hospitals will certainly use this, but even more important, small outlying clinics which don't have highly technical sterilization disinfection departments used to handling chemicals and disposal and protecting the workers. This is perfect for an outlying small clinic where, again, you don't have people expert in necessarily sterilization disinfection because it's fast and it's easy and there's nothing to dispose of. So it has many advantages, particularly in those smaller, a clinic with just two gastroenterologists using, or two urologists using rectal probes to look at the prostate, or in an obstetrics gynecology clinic where they're using vaginal probes to look for at the ovaries to look for cancer and other issues in the fallopian tubes. That's the major use, I think, is really out in those smaller clinics.
Gotcha. Okay. And then for my last question, I just want to know if you wanted infection prevention leaders listening today, just to take away one practical idea from the conversation, what would you want that to be?
Well, that would be very simple, that all the things that we ideally would want to build into a disinfection system are achieved by this UVC chamber for ultrasound probes. Fast, safe for users, safe for patients. Built into it is that it's achieved appropriate high-level disinfection, readouts so you can keep track of it. So from an ideal standpoint, this is just perfect. It really checks all the boxes off, both for infection prevention, but well as for the physicians who are using it in clinics in terms of meeting all the safety parameters and allowing rapid turnover of patients.
Okay. All right.
Thank you for joining us on this episode of Voice for Infection Prevention. We hope you found our discussions informative and insightful. Remember to subscribe to our podcast for more conversations with experts in the field, and don't forget to leave us a review to let us know what you think. For additional resources and to stay updated on the latest news in infection prevention, visit our website at voiceforip.com. Thank you again for listening. Until next time, stay safe and continue your commitment to excellence in infection prevention.